here today to go through an upper cervical analysis system that is complete from a neurological as well as biomechanical viewpoint. So we have today here Annabelle, who is our wonderful assistant. I'm very grateful that you joined me today. So what we're going to start with is the first question we always have to ask. Do you spend the majority of your day sitting or standing?
Sitting.
Sitting, okay, wonderful. So what I'm going to have you do to start off our analysis is take a seat on the edge of this table while locking your knees back against it. Now in this, take a seat. So lock your knees back against the table, slide back a bit. Perfect, good. Now what we're going to have you do is we're going to have you start by putting your arms up, making fists. Now I like to bring the arms about 1 inch to 2 inches above the shoulder just to give a little bit more leverage as I do this. Now I'm going to press down and I want you to just hold and resist and not allow me to move your arm at all. Okay. Now an alternative method of doing this is to make the arms completely level with the shoulder, have them extend their fingers forward so their hands are flat like this, us placing our hands slightly over the wrist like this and having you lift your arms while I resist. So go ahead and lift your arms and look at that. That arm is much stronger and the patient can feel this, so it's a really good tool in analysis because it allows the patient to understand that there's a deficit as well as the doctor to make his analysis. Now that first part, the first arm check, gave us a weak arm on his left. This is in no way indicative of anything besides subluxation. It's simply a pattern analysis tool so that we know if the patient is either neurologically interfered with or neurologically clear and communicating fully. Now we start our upper cervical analysis. We have you put your arms back up. This patient tests extremely well with the fist move, so I will do the remainder of this with that positioning. However, at any time with any patient, you can do either or. Some patients respond better to one versus the other. So now what I'm going to have you do is lift your arms slightly. We're going to have you laterally flex your head away from the arm that went weak. So we're going to have you laterally flex to the right. Okay, and hold for me, and that goes way weaker. And this indicates a stronger deficit in neurological communication. Next we go laterally flexed to the side of the weak arm. And that is totally strong. My hand is shaking trying to push it down, indicating that he is holding clear when he laterally flexes, thereby removing the neurological interference that is present in his system. Now, the theory behind this, if you will, is that the brain communicates bilaterally the same. It sends action potentials or signals from the nerve to the muscle to contract. Now the brain thinks it's sending the same message to both arms, but because of the malpositioning of the bone and the neurological interference thereof, it creates a deficit unilaterally as compared to the strong side. So when we tilt the head away from it, it creates an even stronger deficit, making that arm weak, and when you tilt towards that side, it removes any neurological interference, getting complete bilateral communication. The next phase of our analysis is rotation. Now I always have the patient rotate towards the side of weak arm. So go ahead and rotate and hold for me. And that's strong. And now rotate away and that's weak. Now the first one, whichever head position made the arm strong with lateral flexion gives you your laterality component. So for Annabelle here, it was a left lateral flexion that cleared the interference, meaning he is a left atlas. So A blank L blank so far. Now when we have rotation occur, he was strong on the left side, which indicates as the head turns, atlas turns, occiput continues to move, creating anteriority on the side of the side that you're looking. So he demonstrated a clear nervous system with left rotation, creating a left anterior position. Had he been strong when he looked to the right, it would be anterior on the right, creating a posterior left. So as of right now, we have an A blank LA listing for Annabelle. Lastly, we're going to have you put your arms back up, and we're going to have you look upwards. And as you look up, it creates a inferior atlas position to prevent the head from toppling off the body. So go ahead, look up, and that's a bit weak. And we're going to have you look down and hold, and that one's the strong one. So when he looks down, atlas comes up superior to prevent the head from tumbling off the body in that position, creating a listing for him of ASLA. So that is our complete atlas listing via the neurological arm assessment. Next, we're going to take the patient and we're going to have him scoot himself backwards, laying on his back flat on this table. Perfect. Here, what we're going to do, and sometimes I lift the patients and shake out their pelvis to remove any muscular contractions that might be interfering with my analysis. I'm taking a leg analysis or a leg length check in which I see that he is a 1/4 inch short on his right leg. Now this isn't telling me anything listing-wise, this is simply telling me pattern again, that there's an upper cervical subluxation present in his system. We have found that upper cervical subluxations coordinate with supine leg checks, while prone leg checks indicate systemic involvement. So what I'm going to have you do, Annabelle, is come on up. We're going to have you come off the table entirely. I will demonstrate this part for the patient so that they understand. We're going to have you kneel on the edge of the table with your feet hanging just slightly off the edge so that they're freely movable for my analysis, and you're going to line your knees up evenly before you lay yourself down for this next part of the analysis. Perfect. Now, I check his leg lengths again, and this time I still see that same 1/4 inch deficit on the right. Again, just confirming that there's some systemic involvement to his subluxation here. I'm now going to ask him to lift both legs at the same time without bending your knees, while I gently apply pressure and relax, and I check to see what happens, and they perfectly balanced out. This indicates to me that he has a positive or a interference at the C1 level when I contact his calves. Next, I'm going to slide my hands in like this between his feet or like this between his toes and prevent him from rotating his toes inward like this. So go ahead and rotate your toes to make your big toes touch each other. 3, 2, 1, relax. And I now check again, and that's actually 3/8 of an inch, a little bit more drastic than the 1/4 inch that he had prior to, meaning that if I were to make a correction in his C2, I would actually be harming the patient rather than allowing them to remove neurological interference. Lastly, I ask the patient to gently press your face into the table for me. 1, 2, 3, relax, and I check again. And that actually made it the 1/4 inch again. It looked like it was slightly shorter than a 1/4 inch, but not quite an 1/8. Which means that it made a minute change in his neurological system, but it certainly wasn't going to clear out the interference and allow full communication between the brain and the body. So we've now determined that his primary listing would be a C1, or a atlas. We come on up. In most patients with hair, we swoop the hair up out of the way, and we contact, finding the occipital shelf, and we come just below it, just off the tendinous mass, so that we can make a contact with the bone itself. This is a challenge that we then put a very light force just with one finger, nothing else touching any other part of the patient's body, and we see how that challenge, which we hold for a maximum 3 seconds, gives us a 3-second window to see that that would not clear out his listing. We then go from the AILP, or the LP position to the LA position, and we see what happens here. And neurologically speaking, that totally cleared out his system. Now, for completion's sake, I will go through the other contact points, although at this point, I wouldn't necessarily need to. RA, and that's the 1/4 inch difference, and RP right here. And that's a 1/4 inch difference. So 3 of the contact points have gave me corresponding information that there's still a neurological interference. However, the one specific spot made that interference disappear and created a balance or an attenuation of the nervous system. So by that, I now know that he's an LA listing, but I still don't have any confirmation of the superior-inferior portion of the exam. So what I now do is I contact that LA spot again, and I put some inferior torque in, and I see if that clears the nervous system, which it does not. And then I put superior torque in, and I see that That totally clears out his neurological system. Now I have two different systems that correspond perfectly with each other, both indicating that neurologically speaking, he's got an interference as a ASLA. I had to think about that for a second. So I now feel confident and comfortable to have the patient come on up off the table and come into knee chest position and get an adjustment, which we won't be doing.
Okay.
Thank you.